Hello students, this is Dr. Frances Munroe from the George Washington University School of Nursing, and I'm here today to provide you with an introduction to ICD-10 coding. So what exactly is ICD-10? ICD-10 stands for the International Classification of Diseases, the 10th revision. Clinical modifications. It is a revision of the ICD-9 CM system, which was developed by the World Health Organization. ICD-9 has been used by physicians, nurse practitioners, and other healthcare providers to code all diagnoses, symptoms, and procedures recorded in both hospitals and physician practices. The ICD-10 is copyrighted by the WHO, which owns and publishes the classification. The transition from the current version, the ICD-10, occurred in October of 2015. ICD-10 has a list of approximately 2,000 diseases and replaced ICD-9, which was originally developed and implemented around 1978. ICD-10 was developed in 1994, but it took us almost 20 years to develop this for use in the United States. ICD-10, in contrast, has approximately 68,000 codes and is maintained by the National Center for Health Statistics. ICD-10-CM is used in all U.S. healthcare settings and is just usually referred to simply as ICD-10. It is the clinical modification and procedure coding system. It has the two parts. ICD-10 procedure coding system stands for PCS, is used only in the inpatient setting in the hospital and will not be addressed in today's overview. So ICD-10 is the enhanced or mature version of ICD-9. As we said earlier, it's the 10th revision of the International Coding System. ICD-10 is organized into 21 chapters of disease, very similar to ICD-9 chapters, except that it has increased granularity and specificity, greater accuracy for reimbursement and billing purposes. ICD-10-CM and PCS both began in the U.S. after the implementation deadline of October 1, 2015. It's important to note that no changes were made to the CPT coding system for outpatient procedures done in the office setting. So what are the benefits? Why did we change to ICD-10? The Health Insurance Portability and Accountability Act, also known as HIPAA, was implemented in 1996, and the final ruling came about in 2009 by the Department of Health and Human Services. Basically, the Centers for Medicare and Medicaid Services made the announcement in 2010 that ICD-10 would be implemented in order to give us better clinical documentation and accurately capture the clinical data and severity of illness. So these were important changes that came about through legislature that occurred almost 20 years ago, but are now being finally implemented. You can take a look at the original rulings at the CMS website listed on the screen. The compliance timeline was a long one. As you can see, the final rule was published in January 2009, and in March they began the design for the implementation. 2010-2011 saw a lot of testing that occurred, and then the final ruling was put into place. On January 1st, 2012, the 510 compliance date was built in. And again, there was a lot of testing done during that time. The deadline had been moved back originally from 2013 and pushed forward all the way to 2015 of this past year. What exactly is version 5010? Well, there is a new medical data code set, the HIPAA version 5010, and it can accommodate the extra space for the ICD-10 codes. These are the actual bills that are submitted to the insurance companies that have to have all the data on them for reimbursement. The previous HIPAA code 4010 could not accommodate the larger ICD-10 codes, which are up to 7 digits in length. So once the HIPAA version came into being, ICD-10 implementation needed to be rolled out. So version 5010 allows for a greater number of diagnosis codes per claim. And this uses the enhanced data elements for the electronic transmission of data and claims. So again, all to do with the implementation of HIPAA, and then the ACA that was implemented just a few years ago. So what are some of the benefits of using version 5010? Well, for providers, it actually simplifies the reporting of important data on the claims, and it does incorporate greater specificity of the clinical information. Instead of just reporting that a patient might have an ear infection, you're now going to be more specific with whether it is a new or recurrence or a chronic ear infection, which side, right or left, and greater detail whether or not there was a rupture of the TM or not. The version 5010 also removes redundant or unnecessary information, and it does give us the ability to measure healthcare services across time. It eliminates inconsistencies between the different payers. That would be the insurance companies or Medicaid, Medicare. It does decrease the need for supporting documentation. So cleaner claims and faster payments actually puts more money back into the healthcare practices. So some of the other benefits of version 5010, as you can see, for the payers, it simplifies and clarifies their transactions. It helps to facilitate increased accuracy of the transmission of data, greater efficiency in billing. There's better fraud detection methods, allows for the new diagnoses and treatments that are yet to be developed. And overall, the hope is that it reduces administrative costs because there's more automation and less manual scrubbing and handling of the data and the claims that often went on in the past. So let's look at the overall benefits of ICD-10 for providers. More specific diagnoses and treatment options. This helps us to better define patient services, helps to report the quality measurements for the agencies. It helps to improve accuracy of documentation that supports meaningful use criteria, and ultimately helps to improve communication among the healthcare providers, whether it's the specialists to the family practice providers or vice versa. For the payers, there's better data analysis and benefit design. Hopefully, there's better healthcare management and new product design, and a decreased reliance on claims being resubmitted, asking for more provider documentation and supplemental data. Some of the barriers to change that we have seen with the implementation of ICD-10 were the requirements for system upgrades and new software installation. And again, a lot of this was built right into the electronic health records. There was a lot of extra time and cost to train staff, providers, business managers. A lot of time needed for internal and external testing of all of the new coding systems and those electronic transactions using those version 5010 forms. Productivity levels may be suffering as a result, And the new system is very large, difficult to put into the use of code books that many of the offices were using. There could be an increased number of rejected claims initially, and this has been reported by Medicaid and Medicare. And of course, there has been the revision of work processes for ICD-10 codes, so things such as the super bills, encounter forms, electronic health records, quality reporting tools, all of these have had to be updated and upgraded with training for all of the providers and managers involved. So let's take a look at some very specific differences, compare and contrast ICD-9 with ICD-10. As you can see, the number of characters is increased from 3 to 5 to 3 to 7 in ICD-10. The amount of codes is very much increased, up to 68,000 codes in ICD-10. Again, it's going to be much more difficult to memorize codes, which we used to do with the ICD-9. Here, the digits are all laid out. The first digit in ICD-10 is alpha. Digits 2 and 3 are numeric. Digits 4 through 7 are either alpha or numeric. And then there is a dummy placeholder X, which is a flexible feature that is used for adding more codes. The specificity is improved, the accuracy is improved. Hopefully this will help with data analysis and research. And the other point that is very important is that this supports worldwide interoperability. The United States was one of the last countries to adopt ICD-10. It has been used in Europe for many, many years. Next, let's take a look at some new features of ICD-10. Specifically, injuries are classified by their anatomical site and severity instead of just the type of injury. We are now very specific in mentioning whether it is the right, the left, or bilateral part of the body that is affected. The acuity and chronicity of illness is included. Any associated conditions and or complications are also linked to the diagnoses, as I mentioned earlier, whether it's recurrent, whether there's a rupture of the TM. Causality is based upon identification of the clinical organism. And for a quick reference of this information, you can go to the CMS website, theroadto10.org. Gives you a lot of great information about how ICD-10 incorporates greater specificity and information in the outpatient setting. There are also some added extensions for various episodes of care. So now you're going to put in codes for an initial encounter versus just a follow-up visit or subsequent versus a routine evaluation. V and E codes are no longer supplemental, and now they are incorporated into the main classification. These are your injury codes. The OB codes now add specific trimesters to all of the OB codes, so this is very helpful. And there are a huge amount of expanded codes for diabetes, including over 200 codes with 9 different sections for every one of the associated manifestations and complications of diabetes. We still have the unspecified and other specified in ICD-10. They may be familiar to you from ICD-9, where we talked about not otherwise specified or NOS. And now that becomes unspecified in ICD-10. And not elsewhere classifiable is NEC in ICD-9, and it is now known as other specified in ICD-10. Next, I'd like to take you right to the website, roadto10.org, and we're going to take a look at some of the interactive case studies. In each of the scenarios, you can be presented with a sample medical case, and you will be asked several questions about how to properly document and code that case using ICD-10. After you complete the question, then you will be presented with your results with a comparison to your peers, as well as a sample way to code the case in both ICD-9 and ICD-10. New scenarios are released every week by CMS, so this is a really neat tool to use, and I'm going to show you just one of the examples and how to use it. So here's an overview of the first page once you click into the link to the Road to 10, and as you can see on the one side you'll see the name of the scenario and which of those are new, and then the condition or category that those case scenarios fall under by body system. So if we take scenario number 1, which is atrial fibrillation, you can look at the case of a 56-year-old male who comes in complaining of episodes of irregular heartbeat. He had been evaluated for over the past year and has documented recurring episodes of atrial fibrillation. He is being treated for ongoing hypertension, and he has not been taking his medication as he feels that he doesn't need it. His past medical history is otherwise unremarkable. And on assessment, you determine that he's got intermittent atrial fibrillation, hypertension, and poor compliance to his medications. So if you'd like to quiz yourself, which of the following needs to be documented to select the correct ICD-10 code for this case? And as you see, I've highlighted the answer, which is the nature of the atrial fibrillation, because it's very important for this code that you know specifically what type it is. In the past, the ICD-9 codes down below, we would have just coded this simply as atrial fibrillation and benign essential hypertension. Now, using ICD-10 codes, we're going to be much more specific and listed as paroxysmal atrial fibrillation, essential primary hypertension, and specifically look at the code for underdosing of other antihypertensive drugs, subsequent encounter, how specific that is. So ICD-9 was able to capture just the overall condition, but did not tell us specifically whether it was acute, chronic, persistent. ICD-10 captures those concepts as long as you document the exact nature of it. And then the concept of benign versus malignant hypertension in ICD-10, we're just using one code for either essential or primary hypertension. And now in ICD-10, we can capture the ability to talk about underdosing of medications or problems with noncompliance. So you can see a lot of difference in those. So bad mojo is not a diagnosis. If we take a look at our role as clinicians, it is important that we document as accurately as possible the healthcare condition of the patient and the services that we provide to maintain their health care. The role of the coding professional, who is present in most of our healthcare organizations, is to assure that the coding we do is consistent with the documentation that we're providing in our notes. And lastly, the role of the business manager is to make sure that all of the billing is done accurately, that it's coded and supported by the documentation of facts. Here are some additional helpful resources for you to understand some of the coding things that we talked about today. As you see, there's an American Academy of Professional Coders, the American Health Information Management Association, the AMA has a lot of fact sheets in this regard. And of course, those additional resources that I showed you from the Centers for Disease Control, the Centers for Medicare and Medicaid Services, the Healthcare Information and Management System Society. Optum 360 has a nice website on a coding companion for primary care, and the World World Health Organization itself has some very good ICD-10 resources. You can go back and practice on the road to ICD-10 and do some more of the case scenarios. Hopefully you'll find this presentation has been helpful. Thank you.